Praise be to Allah, the cherisher and sustainer of the worlds. I'm Dr. Ramsha Mushtaq Khan, and today I have the opportunity to present on the topic Hepatitis B under the kind supervision of Professor Dr. Saira Afzal. Quote of the day: everything begins with a thought, and thoughts are turned into plans, and plans into reality. Content outline: Introduction to Hepatitis B, Dynamics of Disease Transmission, Epidemiological Determinants, Clinical Features and Complications, Prevention and Control Measures, Milestones towards Global Hepatitis B Elimination, Recent Advances, and Multiple Choice Questions. At the end of this presentation, the participants will be able to understand the epidemiology of hepatitis B, including phases of infection and its complications, describe the dynamics of disease transmission and the epidemiological determinants, discuss strategies for preventing and controlling hepatitis B, including vaccination, universal precautions, and screening and testing, and recognize the global recent advances in the context of hepatitis B. Hepatitis B is an acute systemic infection with major pathology in the liver caused by the hepatitis B virus, transmitted usually by the parenteral route, and clinically characterized by a tendency to a long incubation period from 4 weeks to 6 months and a protracted illness with a variety of outcomes. Usually, it is an acute self-limiting infection which may be either subclinical or symptomatic. In approximately 5 to 15% of cases, hepatitis B virus infection fails to resolve, and the affected individuals then become persistent carriers of the virus. Persistent hepatitis B virus infection may cause progressive liver disease, including chronic hepatitis and hepatocellular carcinoma. There is also evidence of a close association between hepatitis B and primary liver cancer. Hepatitis B virus can form a dangerous alliance with the Delta virus, HDV, and produce a new form of virulent hepatitis, considered a widespread threat for much of the world. Problem statement. Hepatitis B is endemic throughout the world, especially in tropical and developing countries, and also in some regions of Europe. Its prevalence varies from country to country and depends upon a complex mix of behavioral, environmental, and host factors. In general, it is lowest in countries or areas with high standards of living. The hepatitis B virus infection is a global problem, with 66% of the world's population living in areas where there are high levels of infection. More than 2 billion people worldwide have evidence of past or current HBV infections, and 350 million are chronic carriers of the virus, which is harbored in the liver and causes an estimated 820,000 deaths annually. Categorization of countries based on endemicity. Based on the different hepatitis B surface antigen carrier rates, countries can be divided into 3 categories, with high endemicity, more than equal to 8% of the carrier rates, intermediate endemicity 2 to 8%, and low endemicity with less than 2% of the carrier rates. Countries of the region can be divided into three epidemiological patterns. Type 1 occurs in Nepal and Sri Lanka and is characterized by a low hepatitis B surface antigen carrier rate of 0.9 to 1%. Type 2 can be found in Pakistan, India, and Maldives, where the carrier rate is high in the general population from 5 to 7%. And type 3 is observed in Bangladesh, Korea, and Thailand, where there are carrier rates is very high and ranges from 9% to 12%. Hepatitis B, source or reservoir. The source is the hepatitis B virus from the Hepatinovirus family. Reservoir is the carrier and cases humans, and environmental surfaces for at least 7 days. The modes of transmission include contaminated blood, bodily secretions, including saliva, vaginal secretions, and semen of the infected person. And the susceptible host include healthcare personnel, recipients of blood transfusions, infants of carrier mothers, sexual activists, percutaneous drug abusers, and immunocompromised patients. The ABCs of viral hepatitis. Viral hepatitis is an inflammation of the liver due to a viral infection. There are three main viral types: hepatitis A virus, hepatitis B virus, and hepatitis C virus. The hepatitis A virus is transmitted by ingestion of contaminated food and water and direct contact with an infected person. The hepatitis B virus is transmitted by contact with infected blood and bodily fluids, mother to child transmission, and unprotected sex, whereas the hepatitis C virus is transmitted by unsafe injection practices, infected blood or organ transplant, transfer, or and unprotected sex. For the worldwide incidence, 2 billion people are infected by hepatitis B virus, and chronic infection can lead to liver cancer or cirrhosis. The prevention strategies include vaccination, blood screening, protected sex, and treatment with nucleoside or nucleotide analogs and pegylated interferons. The symptoms of all types of hepatitis include fever, fatigue, loss of appetite, nausea, abdominal pain, joint pain, and jaundice. It is not possible based on symptoms to differentiate among the different viral types, and laboratory confirmation of the diagnosis is essential. In case of hepatitis B virus, the detection of the hepatitis B virus surface antigen, and for acute infection, IgM and anti-hepatitis B or antibody, PCR test to detect the viral DNA. The major differences between the three types of viruses: the transmission route for hepatitis A, it is bowel; for hepatitis B, it is body fluids; and for hepatitis C, it is circulation. Vaccines are available for hepatitis A and B, and no vaccine is currently available for hepatitis C. Whereas there is no cure for hepatitis A and B, and treatment is available for hepatitis C. Epidemiological determinants. The epidemiological determinants include the epidemiological triad, including the susceptible host, favorable environment, and the pathogen. The agent factors include the hepatitis B virus from the adenovirus family. It is a DNA virus. The agent is the hepatitis B virus, also called as the Dane particle. The source of infection include humans, carriers, and cases. Period of communicability is from the incubation period for a month before jaundice and acute phase of the disease. An incubation period ranges from 30 to 180 days. Median incubation period is about 75 days. Period of communicability is usually several months, occasionally years in chronic carriers, or until the disappearance of hepatitis B surface antigen and the appearance of surface antibody. Host factors. The outcomes of hepatitis B infection are age dependent. Acute hepatitis B occurs in approximately 1% of perinatal, 10% of early childhood from 1 to 5 years of age, and 30% of late, more than 5 years of age hepatitis B infections. Mortality from fulminant hepatitis B is approximately 70%. The development of chronic hepatitis B infection is inversely related to age and occurs in approximately 80 to 90% of persons. Host factors infected perinatally and 30% infected in early childhood, less than 6 years, and then 5% infected after 6 years of age. High-risk groups. The annual incidence of hepatitis B virus infection in surgeons is estimated to be 50 times greater than that in the general population and is more than twice that of other physicians. Other high-risk groups comprise recipients of blood transfusions, healthcare and laboratory personnel, homosexuals, prostitutes, percutaneous drug abusers, and infants of hepatitis B carrier mothers, recipients of solid organ transplants, and patients who are immunocompromised. Serological screening and vaccination of high-risk groups is highly recommended. Hepatitis B and HIV infection. It is estimated that 10% of the 40 million people infected with HIV worldwide are co-infected with hepatitis B virus. Although hepatitis B virus infection appears to have a minimal effect on the progression of HIV, the presence of HIV markedly increases the risk of developing hepatitis B virus-associated liver cirrhosis and hepatocellular carcinoma. The mortality rate increases among HIV positive people due to HPV co-infection, both before and after commencement of highly active antiretroviral therapy. The hepatitis B virus has three distinct antigens. The surface antigen, also known as Australia antigen, which is hepatitis B surface antigen, core antigen, which is hepatitis C core antigen, and envelope antigen, which is hepatitis B E antigen. These stimulate the production of corresponding antibodies, for example, surface antibody, anti-HBs, core antibody, anti-HBC, and envelope antibody, anti-HBe. These antibodies and their antigens constitute very useful markers of HPV infection. Patients with HPV infection are expected to have one or more HPV markers. These are the serological markers of hepatitis B, including three antigens: hepatitis HBsAg, which is the surface antigen and correlates with acute or chronic hepatitis B virus infection; HBe antigen, which correlates with hepatitis B virus replication and infectivity; and four antibodies: anti-HBC, which correlates with previous or ongoing contact with hepatitis B virus; IgM anti-HBC, acute or exacerbation of hepatitis B virus; anti-HBs, which correlates with recovery and immunity, that is vaccination; and anti-hepatitis E antibody, which correlates with lower hepatitis B virus replication and remission. This figure shows the blood levels of serological markers. At the x-axis, we have months after exposure and the levels of detection of antibodies, the relative concentration of reactants, hepatitis surface antigen, hepatitis surface and antibody, hepatitis core antibody, and hepatitis O anti-surface. This is the serological test interpretation. In susceptible individuals, hepatitis S antigen is negative, and all three serological markers are negative. In vaccinated, only hepatitis surface antibody is positive. In case of past infection, both antibody to surface antigen is positive, and antibody to core antibody is also positive. In case of acute infection, hepatitis B surface antigen and anti-HBC is positive. And in case of chronic infection, hepatitis B surface antigen and anti-HBC IgG is positive. Clinical features. Symptoms of hepatitis. The symptoms of hepatitis B include loss of appetite, jaundice, fever, dark or pale urine, nausea and vomiting, pain in the right side of the abdomen, joint pain, hives, headache, fatigue and weakness. So the early signs include muscle pain, myalgia, joint pain, arthralgia, headache, fever, and nausea. And the telltale signs include the jaundice and polyuria, darkening of the urine. Prevention. Hepatitis B recombinant vaccine. Hepatitis B vaccine is available as a monovalent formulation or in fixed combination with other vaccines, including DPT, hepatitis A, and inactivated polio. When immunizing against hepatitis B virus at birth, only monovalent hepatitis B vaccine should be used. The dose for adults is 10 to 20 micrograms initially, and again at 1 and 6 months. Children under 10 years of age should be given half of the adult dose at the same time intervals. For the greatest reliability of absorption, the deltoid muscle is preferred for injection, and anterolateral aspect of thigh in case of infants and children less than 2 years. In countries where a higher proportion of hepatitis B virus infection is required perinatally, specifically in countries where the prevalence in the general population of chronic hepatitis B virus infection is more than 8%, the first dose of hepatitis B vaccine should be given within 24 hours after birth to prevent perinatal transmission. The complete vaccine series induces predictive antibody levels in more than 95% of infants, children, and young adults. After the age of 40 years, Protection following the primary vaccination series drops below 90%. By 60 years, protective antibody levels are achieved in only 65 to 75% of the vaccinees. The duration of protection is at least 15 years or lifelong. Infants born prematurely with low birth weight, less than 2,000 grams, may not respond well to vaccination at birth. In such cases, the vaccine should the vaccine dose given at birth should not be counted towards the primary series, and 3 additional doses should be given according to the National Immunization Schedule. Immunosuppressive illnesses are associated with reduced immunogenicity of the vaccine. The high-risk persons for whom the vaccination is recommended are persons with high-risk sexual behavior, partners and household contacts of hepatitis B surface antigen positive persons, injecting drug users, persons who frequently require blood or blood products, recipients of solid organ transplantation, those at occupational risk of hepatitis B virus infection, including healthcare workers, and international travelers through hepatitis B virus infection endemic countries. Hepatitis B vaccine is contraindicated for individuals with a history of allergic reactions to any of the vaccine's components. Neither pregnancy nor lactation is a contraindication for the use of this vaccine. Hepatitis B immunoglobulin, the recommended dose is 0.05 to 0.07 ml per kg of body weight, and 2 doses should be given 30 days apart. Hepatitis B immunoglobulin provides short-term passive protection, which lasts approximately 3 months. Since the median incubation period is lower than 100 days, 2 doses of hepatitis B immunoglobulin given 1 month apart should suffice. The general use of hepatitis B immunoglobulin for long-term prophylaxis has not been recommended because of its limited availability, its high cost, and the risk of complications through repeated use over a long period of time. For immediate protection, hepatitis B immunoglobulin is used for those acutely exposed to hepatitis B surface antigen positive blood. The hepatitis B immunoglobulin should be given as soon as possible after an accidental inoculation, ideally within 6 hours and preferably not later than 48 hours. At the same time, the victim's blood is drawn for hepatitis surface antigen testing. If the test is negative, vaccination should be started immediately and a full course is given. However, if the test is positive for surface antibody, no further action is needed. Passive and active immunization, the simultaneous administration of hepatitis B immunoglobulin and hepatitis B vaccine is more efficacious than hepatitis B immunoglobulin alone. Hepatitis B immunoglobulin does not interfere with the antibody response to the hepatitis B vaccine. This combined procedure is ideal both for prophylaxis of persons accidentally exposed to blood known to contain hepatitis B virus and for prevention of the carrier state in the newborn babies of infected mothers. Hepatitis B immunoglobulin should be given as soon as possible and within 24 hours if possible. Hepatitis B virus vaccine, 1 ml, should be given intramuscularly within 7 days of exposure, and second and third doses should be given 1 and 6 months respectively after the first dose. Other measures, all blood donors should be screened for hepatitis B virus infection, and those positive for Australia antigen should be rejected. Voluntary blood donation should be encouraged because purchased blood has shown a higher risk of post-transfusion hepatitis. Health personnel should be alerted to the importance of adequate sterilization of all equipments. In the practice of simple hygienic measures, carriers should be told not to share razors, toothbrushes, and use various methods of contraception. Also, they should not donate blood. Now for the recent updates, the management of hepatitis B in pregnancy. This statement has the objective to provide evidence on the management of hepatitis B in pregnancy and on the prevention of hepatitis B. The outcomes include reduced transmission of hepatitis B from infected mothers to infants, reduced incidence of hepatitis B in the population through immunization of infants. The summary of recommendations. Recommendation 1 includes screening and vaccination. Universal screening for hepatitis B is recommended for all pregnant women, regardless of previous testing or vaccination. All hepatitis B surface antigen positive women should have household contacts, other children, and sexual partners screened. Those that are not immune or not already infected should be vaccinated. All healthcare workers should be vaccinated and take standard precautions against exposure to blood and bodily fluids should be used. Antenatal management. Hepatitis B surface antigen positive women, particularly those with a high viral load, should be counseled about the potential risk of transmission with invasive procedures. All hepatitis B surface antigen positive women should be tested for hepatitis B envelope antigen and anti-HBe and HBV DNA levels to identify pregnancies at increased risk of post-exposure prophylaxis failure. In women who are candidates for antiretroviral therapy, tenofovir is recommended as a suitable first-line agent. Recommendation 3 in intrapartum care, invasive procedures such as fetal scalp electrodes and fetal scalp blood sampling in labor should be avoided. Hepatitis B infection should not alter mode of delivery, and cesarean section should be reserved for usual obstetric indications. Postpartum. It is recommended that all newborn infants receive a monovalent pediatric formulation of hepatitis B vaccine at birth within 24 hours. Following this birth dose, 3 doses of a hepatitis B containing combination vaccine are recommended for all children at 2, 4, and 6 months of age. If an infant has not received a birth dose within the first 7 days of life, a primary 3-dose course of a hepatitis B containing combination vaccine should be given at 2, 4, and 6 months of age. Catch-up of the birth dose is not necessary. In addition to routine vaccination, infants born to hepatitis B surface antigen positive mothers should receive passive immunization with hepatitis B immunoglobulin at birth, preferably within 24 hours and certainly within 48 hours. It is recommended for all infants for the hepatitis B surface antigen positive mothers to have a serology testing at 9 months of age and refer to a specialist if hepatitis B positive. This is the WHO's global hepatitis strategy, and all WHO member states endorse aims to reduce new hepatitis infections by 90% and deaths by 65% between 2016 and 2020. Moving on to the MCQs. A 40-year-old male patient presents to a local clinic with abnormal liver function tests and a history of IV drug abuse. One of the following most appropriate initial tests to evaluate for hepatitis B infection would be A. HBsAg, B. HBeAg, C. anti-HBs, D. anti-HBc, and E. anti-HCV.
A.
Yes, the answer is A. A patient presents to the OPD with a positive test for hepatitis B surface antigen, HBsAg. One of the following, the most appropriate next step should be A. Administering hepatitis B immunoglobulin, testing for hepatitis B envelope antigen, testing for hepatitis B core antigen, testing for hepatitis B envelope antibody, and testing for hepatitis B core antibody.
E.
No, the answer is B. Testing for hepatitis B envelope antigen. A 60-year-old male patient presents with a positive hepatitis B surface antigen test and elevated liver enzymes. Of the following, the most appropriate next step should be A. Administering hepatitis B immunoglobulin, testing for hepatitis B envelope antigen, testing for hepatitis B envelope antibody, referring to a specialist for further evaluation, and initiating antiretroviral therapy. Any guesses? So the answer is E, initiating antiviral therapy. A healthcare provider is caring for a patient with acute hepatitis B infection. Of the following, the most effective intervention in reducing disease transmission to others is A. Administering the hepatitis B vaccine, B. Administering the hepatitis B immunoglobulin, C. Testing for hepatitis B envelope antigen, B. Providing education about safe sex practices, and E. Initiating antiretroviral therapy. So the answer is D, providing education about safe sex practices. A healthcare provider is caring for a pregnant patient with a positive hepatitis B surface antigen test. Of the following, the most appropriate intervention to reduce the risk of transmission to the newborn is A, administering active and passive immunization to the newborn, B, administering active and passive immunization to the mother, C, administering antiviral therapy to the newborn, D, administering antiviral therapy to the mother, and E, performing a cesarean section delivery. So the answer is A, administering active and passive immunization to the newborn. MCQ number 6, vaccinator is administering hepatitis B virus vaccine to a group of adults at a community camp. Of the following, the preferred route of administration of hepatitis B virus vaccine is A, intramuscular injection in the deltoid muscle, B, intravenous injection in the deltoid muscle, C, intramuscular injection in the anterolateral aspect of thigh, D, intravenous injection in the anterolateral aspect of thigh, and E, intradermal injection in the deltoid and thigh.
A.
Yes, the answer is A. A public health researcher is studying the risk of hepatitis B virus transmission among healthcare workers in a hospital setting. Of the following, the highest odds of contracting hepatitis B virus infection might be for A, doctors, B, physicians, C, surgeons, D, laboratory staff, and E, paramedical staff. So the answer is C. Yes, the answer is C. A public health researcher is studying the risk factors for hepatitis B virus transmission. Of the following, the highest risk for hepatitis B virus transmission is associated with A, exposure to contaminated food or water, living in a crowded or institutional setting, C, casual contact with an infected person, D, IV drug use and needle sharing, and E, sexual contact with an infected person.
D.
Yes, the answer is D. Serological testing on a blood sample from a patient suspected to have an acute hepatitis B virus infection. Of the following, the test results show indicating a resolved acute hepatitis B virus infection is HBsAg negative, anti-HBc negative, and anti-HBs positive. B, HBsAg negative, anti-HBc IgM positive, and anti-HBs negative, anti-C HBs AG positive, anti-HBc IgM negative, and anti-HBs negative. B, HBsAg positive, anti-HBc IgM positive, and anti-HBs negative. And E, HBsAg negative, anti-HBc IgM negative, and anti-HBc negative.
A.
Yes,
B.
the answer is A. A low birth weight baby is born to a mother who is positive for hepatitis B. According to CDC guidelines, the baby should be vaccinated within A, 6 hours, B, 12 hours, C, 24 hours, D, 48 hours, and E, 72 hours.
C.
Yes, the answer is C. This is the key of the MCQs. Please like and subscribe our YouTube channel, and thank you very much.